While attending our webinar today, brought to you by Mission Lifeline Montana. Mission Lifeline Montana is an initiative supported by the American Heart Association and funded by the Helmsley Charitable Trust to help build a successful STEMI system of care in Montana. Today we have the chairman of Mission Lifeline Montana, Dr. Douglas Waldo, who's also an interventional cardiologist with Benefits Heart and Vascular, and he talked to us today about acute coronary syndrome. Doc, I'll pass the torch to you.
Thank you, Tony. A set of slides concerning acute coronary syndrome. And the first slide you see first shows several terms that you may have heard over the last several years that relate to the acute coronary syndrome, terms such as unstable angina or crescendo angina. Others you may have heard are subendocardial myocardial infarction or subendocardial MI. The other term that is perhaps most important to us as cardiologists is the term non-transmural MI. Of course, the granddaddy of them all, the final stop in acute coronary syndrome is the transmural myocardial infarction, which is called STEMI. For the information regarding STEMI, there is a webinar that's been by Dr. Brian Raw, and I invite you to please go through one as well. Slide. We have the stages of atherosclerotic vascular disease up to the coronary syndromes. Here, with a normal artery, which shows the red course is the blood column flowing through the artery. Every artery has a intima, the muscle media, and outside tough adventitia, which holds everything together. When we start to see these go develop in an artery, the next one in artery, you see this so-called fatty streak, which is really the first sign of inflammation going on in the coronary artery. If there's inflammation, and we're going to talk about that a bit, you'll see the atheroma develop with that lipid-rich nephrotic core and develops a protective fibrous cap that of early plaque development. This cap turns out to be very important with acute coronary syndrome. The next slide, or the next, not slide, I'm sorry, the next image to the right is a more stabilized plaque, which shows the smaller lipid pool and a very thick, stable fibrous cap. Become a very stable plaque, or down below here where the arrow is showing, more vulnerable plaque, and this is the direction that all patients with acute coronary syndrome start to go in. And they begin to develop a thin fibrous cap, which likely to erode or break open. And the lowest picture you see thrombosis of a ruptured plaque. And what happens, of course, is when that lipid core extruded into the moving blood pool, that's the setup for the typical clotting or thrombosis that occurs in either the non-STEMI or the full-blown STEMI entity and event. This looks like in real time or in real sections. The first thing here, in the first slide, these sections in the left-hand, most left-hand column show a more normal vessel that has only developed a small or early aromatous change along the intima of the artery. There's one here where the arrow is pointing, and there's one here stained slightly differently. As you move to the right, you can actually see the buildup of more plaque, more atheroma, and eventually you start to get into a situation where the aroma has become more built up, starting to fissure or starting to become more unstable. The first ones to the right demonstrate mostly occlusive plaque lesion. Sometimes these lesions have already broken open, thrombosed to some degree, probably caused some chest pain, may have caused a small heart attack. Obviously, the vessel has a choice, the body has a choice to either ice or get rid of the clot that's blocking blood flow, or if thrombosis completely, in which case we're faced with a ST segment elevation MI. Here's this depiction in this next slide of inflammation, and one shows a fairly normal vessel, which is starting to develop an area of inflammation. And what happens here is you can see the different cells that are involved is that first, with inflammation, the endothelial lining becomes more permeable. You get adhesion of an anti-inflammatory inflammatory cells, and to go after the part of the vessel that has become very atherogenic. And you see migration of the cells, the so-called the smooth muscle migration cells, which start to form the atheromatous plaque. With T-cell activation, you automatically know that there's going to be a lot of inflammatory reactives that are being released into the plaque. You start adherence and aggregation of platelets, and in fact, we'll talk about platelets a lot in the treatment of non-STEMI and acute coronary syndrome because of the input from platelets that cause the non-ST segment elevation MIs. The matured plaque undergone a lot of changes with inflammation. The phages are there trying to get rid of foreign materials such as lipids, debris, and start to get the formation of the necrotic core. I'm sorry for the but it's the necrotic core, and the fibrous cap formation is shown. And if you remember, I showed you where you have a thick fibrous cap that's very stable. When it becomes more thinned, then there is a danger of the plaque rupturing and causing thrombosis. We call that type of a plaque an unstable plaque. Now, I need to talk a little bit about treatment effect if we're going to go over our protocol that we're using for non-STEMI. These classifications, Class 1 benefit is much greater than the risk, and types of studies are based on multiple randomized trials. You know this because the guidelines and recommendations that we have on the order sets are based on Class 1 and Class 2 recommendations. In 2, the benefit is still greater than the risk based on most randomized trials that have been done concerning each of the medical therapies that you're going to see listed. It is divided into Class 2A and 2B, and notes there, reasonable to administer treatment. Class B is additional studies or data is needed, but there's enough data that treatment may be considered. Class 3, which we will not list for you, but those are types of recommendations that have shown no benefit or actually have shown harm. And with evidence, important as we consider right order sets, in evidence A means multiple populations were involved in clinical trials, are limited populations, or there's been only a single trial or a non-randomized trial that showed some benefit or at least a trend to being full. And levels of evidence C is that there's a consensus opinion, or there's been some case studies that have shown some benefit. We're talking about some of the therapies we use in acute coronary syndrome. First, of course, is well known to everybody, aspirin. This is a class 1A. Aspirin has been shown to have positive benefit over many decades in all trials that have been run in acute coronary syndrome. Aspirin is a pillar of our therapy, as you all know. P2Y12 receptor inhibitors, and specifically the ones listed below, are used in a dual antiplatelet therapy and class 1 recommendation for non-ST segment elevation MI. One a while, clopidogrel or Plavix, and more recently ticagrelor or Brilinta have been available for acute coronary syndromes. Now, the important point here is that we used, but you both listed because Brilinta has been compared against Plavix in trials. Brilinta is not a prodrug. It's a faster onset of bioavailability. It's a competitive P212 receptor inhibitor, and sometimes you'll hear it called reversible. Now, important points, and I'm going to mention only one trial, was the Plato trial. It's a platelet inhibition and patient outcomes, multi-center, international randomized trial of over 18,000 patients diagnosed with acute coronary syndrome. Nearly 12,000 of these patients were unstable angina and non-ST segment elevation MI. It was, of course, with aspirin, as was Plavix. Ticagrelor was associated with a 1.4% reduction in all-cause mortality, is a difference of 4.5% mortality with ticagrelor in the studies as opposed to 5.9%. And most importantly to those of us on the receiving end for intervention is that ticagrelor had lower rates of stent thrombosis once intervention was accomplished. There's no difference in the major bleeding rates between the two, but we did find that Brilinta needed to be administered with a lower dose of aspirin, or as many of you probably know, does cause more dyspnea in the patients, but this is very reversible and often does cause termination of therapy. The real advantage of ticagrelor is that it has a faster on, faster off effect. Note, as I noted above, it's not a prodrug. It's ready to go to work as soon as it hits the system. A dose of aspirin is needed. Perhaps most importantly for of us taking care of patients after our event is that the platelets recover faster if surgery is planned, either coronary bypass surgery if needed, or any other surgery that the patient needs to undergo. This prasugrel is on this slide as well. Is a P2Y12 receptor inhibitor. It has been used in acute coronary syndrome studies and in treatment. It's here, but it's a black box warning for a higher bleeding rate in patients. And the STEMI trial was a large trial for myocardial infarction. Their final opinion was that it does not have favorable use in non-ST segment elevation MI. We're going over some of our order sets. Here is the first page of the order sets that are in the rural critical access centers. Some are obvious. I like to have the patient get an EKG within 5 minutes of arrival. Vital signs take fairly frequently. I need to be NPO, their cardiac monitor, and they need oxygen. Keep their saturations greater than 94 to 95%. They all need an IV, which is saline locked. The critical access areas need to be able to use center transfer checklist, this is data that we need to collect for the American Heart concerning the non-ST segment elevation MI patients. Some of them will need intravenous fluids. Often they have been sick of their stomach or somewhat volume contracted and some hydration. We need laboratories. We need CBC, their electrolytes. We need their anticoagulation parameters. We need a troponin level. Diagnostics will include portable X-ray, and we already had one EKG, but we like to have EKGs repeated for recurrent chest pain. From a repeat chest pain for recurrent chest pain are often very helpful. Inside is page 2 of the order set on ST segment elevation MI. Some of these are obvious, and you probably know about them already. Aspirin needs to be a chewable 81 milligram, up to tablets to achieve 324 milligrams PO initially. An anticoagulant will need to be chosen. You see that we would like each of the critical access to choose either heparin or ibuprofen. We listed there based on the maximum dosage, the continuous IV infusion. For greater than 75 years, sub-Q given is smaller than the IV push that we use for patients that are younger. Next line shows you the choice for either Plavix 300 milligrams or Ticara 180 milligrams. We've used the small dose of Plavix based on some studies that have been done, and because there's some confusion sometimes on the age of the patient to be treated, it's important that we use the most conservative dose that will be helpful in the patients. Remember that ticagrelor or Brilinta has fastest bioavailability than line shows the nitroglycerin, obviously used sublingually for chest pain, and 5 minutes for up to 3 doses. If having chest discomfort with EKG changes, then nitroglycerin will be started. These patients, if they're not already on a beta blocker, need given at least metoprolol 25 milligrams PO now. The beta is avoided if their systolic blood pressure is less than 90 or demonstrating heart block less than 50 beats per minute, failure or shock, and of course, please don't use it if a patient is having ongoing bronchospasm on presentation. 2 to 4 milligrams is given for chest pain if relieved with sublingual nitroglycerin. So safe to use for vomiting. And then to the glycoprotein question, the one listed there on our order set is integralin. And use integralin or one of the other glycoprotein receptors and inhibitors is high risk, and I've listed what we high risk. We'll talk about that further. Specific for the glycoprotein 2B3A receptor antagonists. The ones listed are insulin and Aggrastat. Riopro or abciximab is also a glycoprotein 2B3A inhibitor, but it's listed here because we tend to use Riopro in procedure on specific conditions and situations. For the purpose of critical access rural mention for non-ST segment elevation MI, we're going to talk about integralin and Aggrastat. Both medicines are specific for the glycoprotein 2B3A receptor. Their binding affinity with tirofiban or Aggrastat Both of them allow the platelets to recover in 2 to 4 hours, and both of them require renal clearance. The question up with these medications for non-ST segment elevation MI is when to use them and who to use them in. Most of these patients are going to be transferred from the critical access centers. Some treating these patients upstream, close quotes, is important for the patient. We call it early invasive strategy in ST segment elevation, MI. The recommendation for upstream 2B3A therapy for high-risk patients. We mean the patients that are demonstrating ST segment elevation depression or in ST segment elevation in contiguous leads, or in biomarkers such as CKMB or troponin. In 60 years, especially if they're diabetic, have a history of ACS, which raises your suspicion level significantly. So, ST segment elevation MI, we're getting this upstream or early on 2A therapy are for you. Studies that have the benefit are the early ACS study and the acuity study. The bottom line in these studies is that bleeding is certainly higher in upstream 2B3A therapy and acute coronary syndrome. The patients that receive deferred treatment, procedural treatment, and patients undergoing PCI. But it's clear that in the selective high-risk patient group, and I've already listed that, those characteristics of a high-risk patient group is listed for you again, that is markedly greater than the risk for reduction in ischemic recurrences and reduction in complications in patients that are undergoing earlier angiography and coronary intervention. And Aggrastat at this point, because some of you may have discovered, is on back order and may not be available for use in the field or even at the PCI centers for quite some time. That reversible antagonist, it blocks the final common pathway to the platelet, and what this is showing here is a platelet with the of the that make platelets either aggregate or disaggregate or be irritated. The thrombin receptors, you have shear forces, and at the top you have clopidogrel and prasugrel, ticagrelor, and the newer one which is coming out, which is an IV preparation of cangrelor. These are the ones that demonstrate active and aggregation effect. Down here is where the 3A inhibitors work, and essentially they block one aggregating another platelet. It's sticky, find platelets, you start to form the clot that is not desirable inside a blood vessel. Dosage and Administration order sets that will include Aggrastat will be available at rural critical access hospitals. This bolus regimen is there for you 25 micrograms per kilogram within 5 minutes, and drip at 0.15 micrograms per kilogram per minute, up to 10 hours. Most likely be transferred well before the 18 hours. Patient with a lower creatinine clearance, then we're going to give the same bolus, but the drip is reduced. Mission Lifeline Montana contacts. These people are available to answer questions or go over any aspects of the order sets that may come up. Free to call any of us about their sets or any questions that might arise concerning our hospital. Thank you.
Dr. Waldo. We have a couple of questions come in as we're presenting. The question deals with the appropriate time to get an angiogram or really take a look at the coronary anatomy for a patient who's undergone an STEMI.
A good question. Refer to the TIMAC study, stands for Timing of Intervention in Acute Coronary Syndrome. And this is done because it was not clear how we should get a patient who's in non-ST segment elevation MI or any form of acute coronary syndrome into the catheterization laboratory to look at their anatomy and decide an intervention. But this helped us conclude that early angiography in the high-risk patients, and again, the characteristics that we listed during this talk, that the angio was more beneficial than delayed intervention in patients with acute coronary syndrome. Another study, however, that followed this one demonstrated that immediate angiography, such as the angiography and intervention that we try to accomplish with the ST segment elevation MI patients, can have no advantage over a slightly more delayed angiography and intervention. Delayed, we mean 12 to 24 hours. That's to be the minimum time for with non-ST segment elevation MI to be admitted to the laboratory for possible intervention. Thank you.
Next question that came in deals with patients that might have a propensity for excessive bleeding. So far, if we're concerned that in our critical access hospitals, what's the recommendation?
This is always a tough question to handle when you're dealing with a patient who's acute ill or bordering on developing an acute MI. Question about the possibility of bleeding, specifically in patients that have a high propensity, as mentioned by Joni, or that have had, say, recent surgery, had a stroke with hemorrhagic transformation. I think the important thing to do is contact our PCI center and talk to the on-call interventional cardiologist to decide between you course of action for that particular patient. Obviously, there'll be risk, but balance that against benefit.
Thank you, Dr. Waldo. So when a critical access hospital gets this order set or uses this order set, should they initiate care or should they try to contact the physician ahead of time?
The whole idea of Mission Lifeline, you have these order sets that have been well developed and thought of by experts across the state as well as the United States, and that we need to have patients receive therapy as fast as possible. We have the leaders working in the critical access centers feel comfortable using these order sets and to initiate as soon as possible in both first and second page that we presented today. The catch, of course, is that if there is a concern about bleeding, which we've discussed briefly just ago, please call the PI center and talk to the on-call interventional cardiologist.
Thank you, Dr. Waldo. There are no further questions. It was a very informative presentation, and we thank you for your time.